in response to the vaccinations. So we choose a different schedule for those patients, or at times after solid organ transplants or bone marrow transplants, whatever immune memory they had, that gets wiped out, to take us through such difficult situations which are not routine, because routine we know, like the back of your hand. We have Dr. Vipul Baweja, our senior consultant, who will take us through this topic, and Dr. Pawan, our co-moderator, is an expert in bone marrow transplant and is heading the BMT center in our hospital. So he will pitch in wherever needed.
Yeah, thank you, sir. Thank you for kind words and introduction. And as Dr. Bhasin rightly mentioned, that immunization, yes, remains the primary domains of us, that is the pediatricians. And here I would like to add on, when we are talking of certain immunocompromised states, the domain extends to even the larger group, especially the colleagues who are working in a scenario like me with a hospital, which has a one of the largest BMT centers and a good oncology departments. We have so many patients after that we have to cater, and our range extends to the age 70 also. And it's not only for pediatricians in a multi-specialty hospital, since now we have more of cancer survivors or bone marrow survivors. All of you will have some or different kind of interaction wherein you will find people looking for vaccinations, or at least sometimes they are not aware of. People forget about vaccinations after going through all this stress and chemo. So maybe when we are more sensitized, we can pick up those groups which are left out. So starting my talk today, just a second. Is my slide screen visible to all of you, Dr. Bhasin, Dr. Swati, can you confirm that?
Sir, your slides are visible.
Yes, your slides are visible,
Okay.
and you can proceed.
Okay.
So first of all, who all are compromised? Who are immunocompromised? So the groups we are discussing today will include organ transplant recipients, which we know are on lifelong immunosuppressions, and they will remain some amount of immunosuppression the whole life. Then there is a group of patients who have received certain chemotherapies for a certain period of time, and because of which they are more immunosuppressed for a fixed period, and then later on they behave differently. Then there is a group which are on long-term steroids due to any reason. It could be bad nephrotics, ADEMS, ITPs, multiple vasculitis. So they also are in the domain of immunocompromised. And as Dr. Bhasin mentioned, the post-bone marrow transplant, where you just wipe off their immune memory and they are just like a new baby after transplant, they are the most vulnerable group. And then we have, yes, certain immunodeficiency states, whether acquired or congenital, who have to live with immunodeficiency. So these are the groups we should know about how all to go about for vaccinations. Now, how does the immunocompromised status matter? We know that immunosuppressive regimens which are used after solid organ transplants use steroids and many calcineurin inhibitors. Now, they both blunt the T and B cell responses and of cellular proliferation, and the antigen stimulation is inadequate. So they don't mount a good immune response due to any infections, and also after certain vaccinations. And out of their because of their lifelong immunosuppression, they are always at a risk of bad opportunistic infections. Now, their immune system is not able to mount a response as effective as in normal subjects. Besides that, there is a subset which has post-transplant hypogammaglobulinemia, which is defined as immunoglobulin G levels less than 600 milligram per deciliter. And they also are more prone to, because of this, recurrent infections because of the inhibit slow cytokine production. So when we are talking about the vaccinations concerns in immunosuppressed, there are certain concerns. The first and foremost, the decision to administer vaccine can be a risk-benefit decision in many situations, because we know we are not going to get a robust response of a vaccine also when we immunize them. Certain situations, live vaccine, even when used, they lose their attenuated status in a host who is little immunosuppressed, and they itself can cause disease due to the vaccine pathogen. Also, a given antibody level, which are seen in studies with normal subjects, may not provide the same protection in an immunosuppressed host. Even when we have immunized, the immunity wanes faster in immunosuppressed children than in healthy ones. So that needs to check on the antibody titers and reconsider the revaccination from time to time. Certain cases, it has also been seen that vaccinations can also flare up of disease activity or end up in a graft rejection. So this is the one of the biggest nightmares, but thankfully very less cases are seen in pediatric, but in adult cases, these are more have been seen, especially in cardiac transplants. But all sex versus benefit, it has been seen that infectious agents per se are more commonly responsible for rejection and complication rather than vaccinations. So overall, the consensus has been that immunizations are more protective, and all opportunities should be taken to cover these immunocompromised patients as far as possible. So before the vaccination considerations should start even before immunosuppression starts. It has been seen that when you stimulate the immune system before the immunosuppression, and later on when they go through a period of immunosuppression, and after that immunosuppression is over, then you give boosters of those vaccinations, that response is much better rather than we starting everything after immunosuppression. So the teams connected with the patient should be sensitized and should administer these primary series early. Sometimes you need boosters, sometimes you have patients who will be totally unimmunized. So you have to catch them early. And not only early, you have to little rush up the schedules depending on what are their needs, how early they need immunosuppression, or how much time they have before organ transplants. So they have to be initiated early and fast. So some certain situations we have to rush up the schedules before the immunosuppressions or before a organ transplant or a bone marrow transplant is done. More so, certain live vaccines won't be possible at a later state, especially so in organ transplants, where they are on lifelong immunosuppressions and you totally lose the opportunity of vaccinating them with live vaccines. And certain vaccines should be must in all scenarios. Most of the studies have laid stress on vaccination with hepatitis B, pneumococcal, influenza, if not all the vaccinations available in our baskets. Now, post-immunizations, we should all know that the first 6 months after transplant or chemotherapies, they show the poorest response because they are receiving or have just finished with the highest doses of immunosuppression. Also, in first 6 months, there is a maximum chance of graft dysfunction and rejection. So we should be very careful in choosing the vaccinations. So most of the centers or healthcare providers postpone immunizations until patients are taking a maintenance immunosuppression, which is around 1 year of age, 1 year after the immunosuppression. Inactivated vaccinations are generally safe in an immunosuppressed patient. and the live vaccines such as the OPV, BCG, MMR, varicella, inhaled flu vaccine, oral typhoid vaccine are most of the time contraindicated, especially in transplant recipients on lifelong separation. Also, we do not use live vaccines when a patient is significantly immunosuppressed, like the patients who are on steroids at the dose of more than 2 milligram per kg or alternate of more than 14 days. So live vaccines are not used until the steroids have been discontinued for at least 1 month. Here we should note that children who are on lesser doses of the steroids, as mentioned above, or those are on inhaled topical therapy, they are eligible for live vaccine wherever applicable. And other immunosuppressant drugs like cisplatin, MMF, CSA, the TAC regime, rituximab, they also called immunosuppression, and live vaccines are not used in the situations where they are being used. Also, we should know there are special situations where we will use vaccinations even if the patient is immunosuppressed or has just undergone immunosuppression, even if we know that a suboptimal immune response is expected. And one of our important situation is, the rabies, the mammalian bites. So this is a situation where you don't take a chance. Even if they are less effective, we do locally infiltrate rabies immunoglobulin followed by anti-rabies vaccine. And here we go a step further that even a category 2 exposure in such patients should receive the immunoglobulin, which is routinely given to category 3 exposures. And also, even a 6th dose on 90 day, at 90th day is recommended for anti-rabies vaccination in immunosuppressed patients. Similarly, when we are doing a wound care and talking about tetanus, in a clean minor wound, the routine TD or TDAP, whatever is applicable, is given regardless of the immunization status. So normally we say that the previous dose is good for 5 to 10 years, but if such a patient is in a situation, we do give a tetanus boosters, and any wound which is beyond the category of clean or minor, even a tetanus immunoglobulin is recommended if available. Another special situation where we use the vaccine is varicella exposure. So not precisely vaccine, here we have to use the varicella immunoglobulin levels. And if it is ideally, if available, the levels should be done. And if the levels are low, then the immunoglobulin is to be given in the doses as displayed. Alternatively, if certain situations we don't have the immunoglobulin levels, we can use the normal human immunoglobulin at the doses 0.2 gram per kg. And the least preferred option, which we sometimes are left with this only, is using a high dose oral cycloprid prophylaxis if the varicella exposure has occurred. Another situation is influenza. So especially if there is a local outbreak or increased activity, the influenza vaccine is still recommended even if we have an immunosuppressed host. And another situation is hepatitis B vaccine. If it is seen that a child is immunosuppressed and it is not totally immunized before with hepatitis B, still hepatitis B is given, even if we know that the response is going to be low. Another area which is often missed when we talk about immunosuppression is immunization of the contacts. So the vaccine strategy should also include the vaccination of household contacts and not to miss the healthcare workers, which includes the doctors, nurses, GLEs, which are working around the patients in the wards. They should all receive all standard immunizations, including, we are talking of the contacts, including the non-transmissible live vaccines. So when you're talking of live vaccines, certain vaccines are non-transmissible like MMR and varicella, and certain are transmissible like oral polio and rota. So immunization with non-transmissible vaccine should be given to all contacts. The immunization with varicella vaccine poses a very low risk to the immunosuppressed. Technically, yes, they can spread, but if the disease outbreak happens around the immunosuppressed patients, then their risk is more. So it has been seen that giving this vaccination to contacts helps in long run, especially if the contacts are seronegative. We should not use the transferable live vaccines like oral polio vaccine, the rotavirus vaccine around a patient who is immunocompromised. And also the immunocompromised host the patient should not handle even the diapers of infants who have been vaccinated with rota or OPV for at least 4 weeks after these vaccinations. And the most strong recommendation is for influenza vaccine, which is recommended annually for all the healthcare workers and household contacts of living with immunocompromised patients. And since now the boundaries are not limit, patients are moving from one country to another, even for treatment and the medical tourism, we should be sensitized and take care of their travel needs. That such a immunocompromised host, when it's traveling to a patient, depending on the geographical region and the area they are traveling, they should be offered vaccinations if they are eligible. And they should be arranged before the travel because they take certain time to mount an immune response. And special the vaccines for typhoid, Japanese encephalitis, cholera, for the patients who are traveling to these endemic areas. Now we take up special situations, vaccine by vaccine. These are different. Now these guidelines can be little confusing and overlapping when we are talking of different groups. Broadly, we first look at the organ transplant groups. Here, the most important vaccine is tuberculosis being rampant in our country, although we are heading towards eradication, but still it remains a big challenge and a big threat in a patient who is immunosuppressed. So every effort should be taken to immunize the child before the immunosuppressed therapy. And if the status is unknown, we do a tuberculin skin test or quantiferon gold test, and vaccination is indicated who produce a negative results with skin test or the quantiferon gold test. Pneumococcal vaccine has high recommendations in all the pre-transplant patients, especially heart, renal, and liver. All the recipients should be vaccinated against pneumococcal, at least 2 doses of PCV13 at least 8 weeks apart. We should make all efforts to give at least 1 dose of PCV vaccine pre-immunosuppression, even if we are rushed up. If the PCV is given, PCV is still given if a situation is there where a host has received only the pneumococcal polysaccharide vaccine, and we see that the wait time is before organ transplant is more than 1 year. If the wait time is more than 8 weeks after PCV, we go ahead and give a polysaccharide booster also. And in certain situations where the wait time is getting extended because of non-availability of organ donors, we keep on using the pneumococcal polysaccharide vaccine as a second and third booster every 5 years if the wait period is more. Beyond third booster, it is not recommended. Influenza, it is the most cost-effective vaccine intervention in this age group. The side effects and risk of vaccination are very minimal. There is no challenge with the availability also. So it is strongly recommended vaccination in all household contacts and the healthcare personnel of the transplant centers also. Influenza vaccination can begin as early as 1 month after transplant also, or even during the immunosuppression, as we mentioned just above, if there is a local influenza outbreak. Now, hepatitis B. Hepatitis B needs a special mentions. For an immunosuppressed patient, they can have a reactivation of latent infections due to immunosuppression. So even we are missing onto their serologies, we should be boosting hepatitis B with boosters. This is especially more so when a transplant is there from a even if it's a non-hepatic graft from a donor who is hepatitis B surface antigen negative, but has core antibody positive. So it covers that risk also. Liver transplants have the highest recommendations of hepatitis B because there can be right away the de novo draft infection, and renal transplants because of the increased risk of exposures through their dialysis preceding the transplants. So it can be given during immune suppression even if the previously in an unimmunized host. Here we use a high dose, the double dose, the 40 micrograms in at least 3 repeated doses. And in patients who are on long-term immunosuppression, monitoring of titers should be done. And wherever we feel that antibody levels are lower than 10 milliinternational units per ml, we give additional booster dose of vaccinations, and revaccinations can be considered every 2 to 3 years if levels are low. So amongst other vaccines, in post organ transplants, there is no very strong recommendation for meningococcal hepatitis A typhoid vaccines, but it has been said one should follow the local guidelines as per the pattern of disease in that area. Now, now a word about the patients who are cancer patients who are post chemotherapy. Here you will see that vaccination charts look very similar to your routine vaccination charts, with only difference that we can categorize these patients under two heads. One which they are previously unimmunized, and another group where they are totally unimmunized. So where they are previously unimmunized, DPT is given in 3 doses. But in a fully immunized lot, we just give a single booster, and this note that this is after 6 months after completion of chemotherapy. Similarly, HIB is given in a schedule as it is recommended for any missed HIB, but even if all doses are given, we give a single booster dose. Injectable polio, 2 doses, 2 months apart, and the third dose after 6 months. But in case totally immunized, then single booster. And even if they were immunized with OPV alone, then also you go ahead and give one single booster of injectable polio vaccine. Similar recommendations are for pneumococcal vaccine, as it is there for a child who has to catch up for a PCV vaccine. But if the child was already immunized, we give a single booster dose after the completion of chemotherapy. Here it is mentioned that the polysaccharide vaccination is not used as a booster for this group of children as compared to the other groups. Other non-live vaccines, again, hepatitis A, no change in recommendations if it was unimmunized, otherwise a single booster. Typhoid, we do a single typhoid conjugate vaccine after the chemotherapy as a booster. And cervical cancer, the data is limited, that even if they are vaccinated, one can consider a single booster post chemotherapy, but for this the data is little limited. Now there are certain non-live vaccines which are given during chemotherapy also, as we had mentioned earlier. So hepatitis B vaccine is given even during chemotherapy in a double dose if the previous status is totally unimmunized, but who have already completed their primary course, for that we do not give, and we give a single booster after 6 months of stopping the therapy. Similarly, influenza vaccine can be considered during chemotherapy also if there are local outbreaks, but generally after chemotherapy and 1 year beyond, they are exited from this high risk group, and we can opt out of influenza vaccines. Post chemotherapy, after 6 months, certain live vaccines can also be given. Now, this is different from the guidelines which we are followed in post-transplant, because in post-transplant cases, they are on regular immunosuppression almost whole of their life. So here the BCG can be given as a single dose if the previous status is totally immunized. But if scar is there, then we do not repeat it, even if post-chemotherapy. OPV is the second choice to IPV. We would always prefer an injectable polio vaccine, but if there is a certain situation, which in today's date is almost nil because IPV is now available in a government sector also. But if used, then we can use 3 doses of bivalent OPV 1 month apart. But IPV always remains a preferred, even if it was unimmunized. MMR, yes, if the unimmunized child, we can use 2 doses 1 to 3 months apart. Similarly for the chickenpox vaccine, and in case of immunization was complete before chemo, then a single booster of each after the chemo. Live HIV vaccine, the recommendation is same. It is always a single dose, irrespective of the status. And rotavirus, generally, the situation will not be there because the age always the child outgrows the maximum permissible age by the time these things are being done and decided. So generally will not be requiring to use the rotavirus vaccine. Now, a third scenario is people living with HIV or other immunocompromised disease. As a take-home summary, in HIV, all the recommended childhood immunization as per IAP or UIP, whatever the sector is following, has to be given, and all inactivated vaccines are absolutely safe. There are only special situations where live attenuated vaccines are contraindicated in severely immunocompromised patients living with HIV, which would be defined as CD4 counts of less than 15% in children up to 5 years, and CD4 count of less than 200 cells per millimeter cube in children more than 5 years. Otherwise, as a routine, all vaccinations are used if the child is not in this category of severely immunocompromised. Now, the question is, a child who gets HIV exposed at birth, what to do? Question always arises in our day-to-day practice. BCG dein ya nahi dein? So the answer is BCG should be given at birth. But yes, if due to any reason BCG has been missed at birth, or a neonate, we have a HIV infection who has been confirmed early by special virological testing, the BCG vaccinations can be delayed until an appropriate antiretroviral therapy has been started and the CD4 counts are more than 25%, which we call as immunologically stable. So for the children who are receiving ART and have not received BCG earlier, it may be given once they are clinically well and immunologically stable, which is the CD4 count is more than 25%, or a count of more than 200 if the age is more than 5 years. OPV, yes, the birth dose will go as per schedule, but further doses we'll prefer IPV over OPV if available. So there is a limited data on this finding that the live attenuated poliovirus existing in oral polio vaccine may actually protect the infected neonates born to HIV positive mothers, protect from getting the mother to child transmission of HIV virus. It is seen that the oral polio vaccine administration in fact does stimulation of the innate immune system at the mucosal levels. So there are not much studies, but more studies are needed on this, that they can be rather protective from getting that very, very, very minimal chance of mother to child through breastfeeding. So they can be protective also. So there is no controversy around the birth dose, that yes, even if they are being born to HIV positive mothers, they will get OPV at birth. Rotavirus vaccine, yes, it is a live vaccine, but it is recommended in HIV exposed infants. It should not be given in children with known severe immunodeficiency, but in a child who is just HIV exposed and not symptomatic, and in such a child, we will not be routinely evaluating the immune status or CD4 counts. The rotavirus vaccine will go as per schedule. Measles. Now, measles in HIV who are not immunologically stable should be postponed. A supplemental dose of measles vaccines containing measles-containing vaccine, whether MR or MMR, it should be given in HIV-exposed infants soon after the diagnosis is made, in case the child is older than 6 months. So here we go prepone the vaccination from 9 to 6 months, who are just exposed but not receiving any ART and they are immunologically stable. and they would still get their routine vaccination at 9 months and 15 months. So this 6 months dose is extra than the routine schedule. And also, if in children who are on ART, and once they become immunologically stable, with that is their CD4 counts increases to 20-25%, they should still get an additional dose of measles vaccines, because the response of measles vaccine is not adequate when they are suppressed. Varicella vaccine, yes, it is given as a routine on the routine schedule to the children who are not severely immunocompromised. Hepatitis B, we should especially look for seroconversions and give boosters as required. And a 4-dose double quantity schedule has been recommended in view of poor seroconversion with routine immunization. Pneumococcal vaccines, the same schedule is followed, and the polysaccharide vaccine should be administered at least 8 weeks after the last dose of PCV if the child is aged 2 years or older in these children. Live attenuated JE vaccine should be avoided. The other vaccines should be used. Inactivated hepatitis A vaccine in the same schedule, and flu vaccine initially same schedule, but yes, annual boosters are recommended beyond 5 years of age also, while routinely we are recommending influenza till fifth year of life only. A single dose of Hib vaccine is also indicated in unimmunized children of more than 5 years of age who have not completed their primary series. Similarly, meningococcal conjugate vaccine, apart from 2 doses, which we give initially, a booster at 2 to 5 years is also recommended in addition to primary series. In adolescent groups, irrespective of the age, in this group, we use 3-dose HPV schedule and not the 2-dose which we say in less than 15 years. So here it is same for every group. And the routine tetanus toxoid and Tdap vaccines are used for adolescent, and the meningococcal conjugate vaccine should be offered in HIV patients. Lastly, we come to the bone marrow transplant. Now, this bone marrow transplant is an entirely different game together. Now, here all the immune memories is created during the pre-transplant ablative myeloablative phase. So when we have a child after or a patient after transplant, their all immune memories cleared. Here, the BCGs, OPV, cholera are not approved for use after BMT. All other vaccines besides them are used after the bone marrow transplant done. Obviously, after a certain period when they are on little immunosuppressive drugs, then all other vaccines are started as fresh, irrespective of the pre-BMT status. So, in a child who is going under bone marrow transplant, we are not rushed up for giving little boosters pre-bone marrow transplant, because the whole thing has to get restart after the bone marrow status. But yes, BCG still remains an important vaccine. Preferably, if they have missed, they should take the BCG vaccine before their bone marrow transplants. So here in this group, the live vaccines MMR varicella are used as is used in other groups. And since they, unlike the solid organ transplants, they are not on any lifelong immunosuppression. So the guidelines are totally different. Exception would be an unfortunate case which ends up at GVHD and has remained on prolonged immunosuppression, or it is receiving repeated blood products, or has to be on certain immunosuppressive drugs to prevent a GVHD. Here the guidelines would change and he will be followed as different. Otherwise, if the whole case has went favorable, then the guidelines are different. So the ICMR guidelines are available for these, which can be followed. So that's the end. We sum up, and I thank for my contributions to Dr. Swati, our consultant pediatric nephrology, Dr. Ravi Bhardwaj, consultant pediatric gastroenterology, and Dr. Silky Jain, who was with us as pediatric hemato-oncologist. Now she has joined Max Chalimar. So now all these slides and academic material which we have just summed up, I know have been rushing through the slides, but these slides and more material are available. You can go to our websites, blkpediatricpractice.com, which is a screenshot of this. Here you have the latest section, which is already being uploaded, and we will be uploading the videos of the talk also in a while. Thank you all. And this is my whole team of BLK-MAX, and one of us will be regularly communicating with you in this weekly webinar session. So thank you.
Okay, thank you, Dr. Vipul, for a
Thank you.
excellent presentation of an exhaustive topic. Actually, it was 3 presentations rolled into one and
Yes.
done in a very timely way. We understand there are going to be a lot of queries. There were some queries, I think, which were addressed as a part of the presentation. Someone wanted to know the vaccination schedule post chemotherapy. I think that question was answered. There's another question about availability of hip vaccine. Is it available isolate as a single vaccine? I don't think it is available as a single hip vaccine alone at present. So, but when you vaccinate for DPT, so you are giving the pentavalent vaccine or the hexavalent vaccine, so it covers the hip. So separate hip vaccination is difficult and not possible. But those children whom you want to vaccinate with hip, you will be needing to vaccinate with the other vaccines. So that problem is overcome. Just about a comment about the local vaccines, as you mentioned, abroad, they do not lay a lot of stress on hepatitis A, typhoid. But I think in a country like ours, where these diseases are rampant and the hygiene conditions are not good, these are spread through orophycal route. So there is no harm in offering these vaccines in these post-transplant patients in a country like ours. And there are a few queries which I think we ourselves are not in a true position to answer. About the problem arises if you have a post-transplant or an immunosuppressed child in the family and you have a sibling who's in the age group where he is needing the primary vaccinations and they are found to be in close contact. So that is a dicey situation. So would you like to say something about such a situation where you have an immunocompromised patient and a family where such a patient is residing and you have a newborn or a young infant who needs the complete vaccination, including the live vaccines? So any recommendations in such a situation?
So the only issue is with the OPV, the transmissible live viral vaccines, which is the OPV and rotavirus. As we mentioned, we just need to avoid a direct contact with the immunocompromised host and the child for 4 weeks. But yes, the problem would be if the host himself is the primary caregiver of the infant, say mother. So there the situations can be challenging that she has to handle the child. It is a very...
No, a situation can arise where a sibling is born or you have a small baby in the family. In joint families, you have another chachi or mosi who's given birth to a small baby. So there's, and while the child is still on immunosuppression, it is a very difficult situation where you need to and you have to vaccinate the newborn or the young baby with all the live vaccines, which while the child is in the immunosuppressive or the patient is still in the immunosuppressive phase, you are not in a position to expose them to these live vaccines.
Yes, sir. The only challenge will be with the rotavirus vaccine. See, OPV we are giving at birth and first 4 weeks will be able to extra cautious. After that, we'll shift to IPV. Now the challenge comes with rotavirus, which at least for next, 8-10 weeks, we will have to take care. make sure that they are not interacting with it. But yes, I think I would not recommend exempt a rotavirus vaccine of a deserving newborn. We will always take precautions to separate.
Yeah.
And now after the COVID pandemic, I think everybody is more sensitized to quarantine in home and segregating into cubicles, floors, up and down. I'm sure families will look some solution of segregating for 4 weeks.
Yeah, but since
So,
it is
yes, sir.
not 3 doses, then it is segregation for not 4 weeks, it is 3 months then. That is a
I know that is a challenge, but I think that has been
do
it will
happen.
be decided on case to case
Always
basis.
try and
Yes, sir.
advise them, if possible, move to the parents, grandparents, where exposure is not there. And then
Yeah.
you did lay a lot of importance upon immunizing the contacts or the family members where you are likelihood of exposure is there in a phase when you cannot yet vaccinate the patient. So that is very important. I think you did mention about it.
Yes, sir.
So,
So-
Dr. Pawan here, sir. Usually in this situation, we always ask for our post-transplant patient, just like we ask whether they have any pets at home or not. So similarly, if we ask for in the family who is living with them, if they have any newborn child or who is supposed to get vaccinated, so live vaccine is there, it is better to segregate them, and we usually advise them to get it segregated.
Yeah.
Because yes, sir, there will be a risk of infection, so we need to take care of that. And usually, once we prepare our patients for transplant, especially the pediatric patients, so we used to tell them that if any child in family who is supposed to get vaccinated, so it's better to isolate the child.
Good input. Thank you, Dr. Pawan.
Yeah, very good presentation, very good overview. And in fact, not an overview, it's about detailed vaccination, especially in immunocompromised patients. So Dr. Vipul, very thank for this wonderful
Thank you,
insight
sir.
about that. And for our patients, like post-transplant patient, we usually tell our even adult patient also, like you mentioned in your, when you started your talk. So you mentioned that even 80-year-old child also, 80-year-old, we usually call them as child because you used to
Yes.
to a pediatrician to get vaccination. We usually tell them, okay, contact local pediatrician to get the vaccination done, because the schedule is almost similar sometimes. But post BMT vaccination schedule is slightly different. Like we used to give all the vaccines together. So sometimes pediatricians, they call us when to give. So we have whole schedule of that, and we used to give the patient's schedule. And so every patient, even adults or elderly patient, also goes to pediatrician for vaccination.
For participants, I like to mention that like we are talking here for ready references, sometimes we don't get to know the references. So we have already uploaded the reference charts, especially the post BMT charts in our websites, which I just mentioned. They just have to write BMT. They will be guided to the post BMT immunization chart, which we normally hand over to the patients in our BLK hospital. So there we have made a reference section which have already uploaded charts. We are using that. I'll encourage all the participants to use these reference sections. They are very useful in our daily day-to-day pediatric practice. It will be useful for them.
And
Thank you,
Dr.
Dr.
Pawan, for your confidence in sending your post BMT patients, adults also to us for vaccination. Similarly, our solid organ transplant units also send their patients to our unit for vaccination. And thanks to them also for their confidence in our unit. Dr. Asim has asked a question, why 4-week quarantine after a rotavirus or vaccine? So, Dr. Vipul, you would like to answer?
Yes, because after vaccinations, they would be throwing up live rotaviruses in their stools, and although they are live attenuated viruses, but if an immunocompressed compromised host gets them, it can be devastating diarrhea at even a bigger age also, not till 1 year of age. So we don't want to take that chance. So their stools are full of live attenuated rotavirus. So
after a vaccine dose, we expect that the virus is continuing to be shed for at least 4 weeks.
Yes, same is true for the oral poliovirus also.
Dr. Swati Bhayana has raised her hand to ask a question. Dr. Swati, you may unmute yourself, please.
Dr. Swati.
Hi, this is Dr. Manas using Dr. Swati's
Okay.
laptop. Hi. Hello,
Hi,
sir.
Dr. Manas.
He wanted, has a query about rabies immunoglobulin.
Not rabies. I just generally had a few queries and comments, and thank you, Dr. Vipul, for a very nice presentation. I'm just using Swati's laptop to discuss a few things. So one thing was, this issue you already raised was this Hib vaccine is not available. So that is a big problem for us, especially when, you have to immunize patients like for splenectomy. So those who are going for splenectomy, and we mentioned the name of vaccines, it is typhoid, meningococcal, pneumococcal. Hib is also one of the vaccine. And then when we want to give Hib is not available alone. So that can be a problem. And you have already acknowledged the fact that Hib is not available. The other comment I wanted to give was that, you said about the vaccination or post-cancer therapy. But I think there is also very important fact that if suppose a 2-year-old child gets cancer and we treat that child's cancer, his vaccination has been given as per the immunocompromised. But after that, as the child grows, whatever are the normal boosters that are expected, those also have to be given. So
Yes.
what happens that the patient gives the vaccination post-cancer treatment and forgets that, he has to get a 5-year booster, 10-year booster, and all those. I think we need to connect with the pediatricians again and kind of tell them that their vaccination has to be completed. One question I wanted to ask was, sir, that you have mentioned that influenza is recommended for 1 year after the completion of therapy and no more influenza after that. What is your comment on that? So for cancer children who have completed treatment, who received one influenza, should we not be asking them to get more influenza for the subsequent years?
See, if we consider to be immunosuppressed a lifelong, yes, yearly boosters are there. What I understand, these guidelines are taken from the pediatric hematology chapter of Indian Academy of Pediatrics, but they have mentioned only, but they have mentioned only for first year. Yes, but we should look at the overall. We see the total age, like till 5 years, IAP is already recommending annual booster till 5 years of age. But yes, if it is beyond 5 years and also beyond 1 year of chemotherapy and received one booster, what I understand from the guidelines is they are not considering the child is as permanently immunosuppressed and they're stopping it at there and they have drawn a line there. But since IAP clearly mentions that this vaccine is to be decided after a one-to-one communication with the parents, and if parents plan, they can go for this vaccine. So we have to be a one-to-one communication that yes, your child is now beyond 5 years, beyond 1 year, as such is immunocompromised. If you still want to go for the vaccine, which we I think counsel to all our parents. So certain people plan, certain people don't plan.
Sure.
I think it should be reasonable enough.
But otherwise, for normally immunocompetent children, what is your general recommendation for influenza?
See, I follow the IAP. I am a very strict IAP following person. I tell them, yes, till 5 years it is recommended by IAP. After that, I offer them that if they want to plan. This is what our academy says if parents
Dr.
plan.
Manas, as far as the IAP recommendation goes, beyond 5 years, if there is a special condition, if the child has a chronic disorder, be of the lungs, be of the heart, be of has a ITDM or something like that, or in this particular case, if you feel he is likely to be on in an immunocompromised status, there is, I think you are free to counsel and give the influenza vaccine. There is nothing against it. And as we know, the strains keep changing. Whenever there is a change in the strain, those children should be offered. There's nothing wrong.
Thank you. Just one last comment. Thank you, Dr. Vipul, for answering that. Just one last comment that, many of these cancer patients and post bone marrow transplant patients require regular IVIG also. because some of them have got very poor IgG levels and we are giving them IVIG. So post IVIG also we need to be careful that some of the vaccinations will not work. So I think that also needs to be kept in mind while managing these children.
Yeah,
Thank
usually
you.
6 months they say after blood products or immunoglobulin, we should postpone even the routine vaccinations. So that guidelines goes in specific. Another point about Hib vaccine, if cost is not a concern, yes, Hib can be procured separately. Till few months back, we were getting the DTWP and Hib combination by Serum Institute by the name of Quadrovax, where we were discarding or keeping the DPT for a separate use and using the Hib vial. But now that is also not available. But the one from Sanofi, which is the Pentaxim, it is available as Hib plus the pre-filled syringe of IPV and DPT. We can, in certain situations, yes, it will be not a cost-effective solution in resource-limited settings, but yes, Hib vial is available. We can always take out that vial, but instead of spending 300-400 rupees, we'll be spending 2,500 rupees per patient. But yes, we can give a Hib to adult patient as a booster pre-splenectomy, as you mentioned, but cost will be a little more.
You're right, Vipul, but Hib is usually a problem in younger children. Post-splenectomy, of course, we would like to cover them with Hib, but most of the times the recommendation for Hib is only till 5 years of age. Post-splenectomy, of course, becomes a special situation where they are prone to these sort of infections.
So there we can use this exception and spend few bucks extra if feasible.
Okay, I think we have had a fairly good round of questions. And if there are no more queries, over to you, Dr. Swati, to round up.
Yeah.
Thank you very much.
Thank you, Dr. Vipul, for an excellent and very detailed presentation. I think it should answer the queries, and thank you for educating us about immunization, which is an important aspect of management of immunocompromised patient. And I also thank our moderators, Dr. Bhasin and Dr. Pawan today. And our next webinar, Telepeds webinar, will be on 25th of May, and we will be circulating the details soon. Thank you so much to all the attendees, and have a good day.
Thank you.
Thank you.